Yeah, good afternoon, everybody. Good afternoon. So I am Aniekeme Etuk, a second-year resident at Thomas Hospital. So I'll be presenting a case on atypical Takotsubo cardiomyopathy, precipitated by gastrointestinal bleeding, with a little review of pathophysiology. No, it's not advancing. All right. So for disclosure, we don't really have anything to disclose at this time. So for outline, we'll follow this outline above. As a word of introduction, Takotsubo cardiomyopathy is a transient dyskinesia, hypokinesia, or akinesia of the left ventricle with apical ballooning. There's also absence of obstructive coronary artery disease with ECG changes and elevation of cardiac enzymes. The incidence is really on the high side these days. It poses a diagnostic dilemma because it's a great mimicker. So the patient may present with what looks like an ACS, and you could think, oh, this is a case of ACS. Meanwhile, there's really no coronary artery disease, so to say. Its atypical variant also occurs with apical sparing. Rather, you have the akinesis to the middle part of the ventricle, so the mid-ventricle. So that's when it's called the atypical cardiomyopathy. For the most part of it, is believed to be stress-induced, and there are lots of varying degrees of triggers, so to say. So for the case presentation, 73-year-old male with complaints of chest pain, palpitations, and shortness of breath. Hospitalized 48 hours prior for gastrointestinal bleeding with a pre-syncopal episode necessitating massive blood transfusion. So on presentation, the patient was tachycardic, although had normal heart sounds. At that time of presentation, we thought of an acute coronary syndrome, like I said earlier on. However, we couldn't really rule out a pneumonia, pulmonary embolism, and aortic dissection at that time. So we got an EKG for the patient, and basically what we saw was just ST segment elevation in the anterior limb leads, as evident by the circular representation there. We also checked the troponins. They were elevated 0.08 for the first check. We tried to trend the troponins over like 3 checks with 6 hours interval. They kind of appeared flat at some point, but not really high rising. We also requested a pro-BNP, which was elevated in the patient, about 37,000 picograms per mil. We also got a chest X-ray, which showed a pulmonary edema. So that's a chest X-ray finding of the pulmonary edema, with the arrows trying to identify where the fluid collection is, basically. So we took the patient for a coronary angiogram, and basically what we saw was a moderate non-obstructive coronary artery stenosis with an ejection fraction of 25 to 30%. So that's like the angiogram looking at the left side, the left coronaries, basically, with its branches. The next one looks at the right coronary with its branches as well. We also got an echocardiogram, and the echocardiogram showed severe hypokinesis of the mid-left ventricular segments with mild hypokinesis to the base and apex of the left ventricle. The EF from the echo, transthoracic echo, was 40%. So that's like an echo picture, trying to retrace that fact as well. We got a CT of the chest, and this was negative for a pulmonary embolism and an aortic dissection, which were possible differentials for this patient at the time of presentation. So for the final stroke working diagnosis, we made a diagnosis of an acute heart failure secondary to atypical Takotsubo cardiomyopathy, precipitated by a recent gastrointestinal bleed. So for management, we started this patient on dopamine infusion for cardiogenic shock, which the patient developed hours while in the hospital. He was on continuous ICU monitoring with eventual weaning off of pressor support. He was also started on goal-directed therapy for heart failure. With improved clinical state, patient was discharged from the hospital. He was followed up in outpatient 1 week, 3 months later, and he was found to be still stable clinically. So a little review of the pathophysiology of atypical Takotsubo cardiomyopathy. The pathophysiology still kind of remains unclear, but there are some postulations to this effect. First of all, you have the catecholamine/stimulus trafficking pathway. Basically, it's believed that you have beta-2 receptors in the apex of the heart. So you have this signaling, this stimulus signaling, where the GS coupling is being signaled to the GI. So this causes like a negative ionotropic effect in the heart, which is responsible for the apical ballooning and the left ventricular dysfunction. That's one pathway. And another one is like the estrogen deficiency pathway. And this is evident when you find atypical cardiomyopathy being prominent in women of postmenopausal age, because by that time they are off estrogen and they tend to have like a lot of atypical cardiomyopathy at that point. Some triggers have also been described, things like ischemic stroke, amiodarone-induced hyperthyroidism and after surgeries, basically following the stress pathway. Anything that causes stress could tip you off and cause this catecholamine surge, basically. Then a little review of the criteria for diagnosing of this disease. Basically, you need, the patient to present with one that seems like an ACS, but once you do your angiogram, you find out that there is no coronary obstruction. So there must be an absence of a coronary artery disease on angiography. Then you must see a transient dyskinesia, hypokinesia, or akinesia of the left ventricle with or without apical involvement. Your EKG will show evidence of ST segment elevation or T-wave inversion, making you feel like, oh, there's an ACS going on. You could also have modest elevation of troponins as well, but there'll be absence of myocarditis or pheochromocytoma, which could cause those features above as well. So as a word of conclusion, Takotsubo cardiomyopathy still poses a challenge with regards to its diagnosis. It should be considered in the differentials in patients who present with what seemingly looks like a myocardial infarction. Echocardiogram plays a vital role in its diagnosis as it aids in highlighting characteristic wall motion abnormalities. Conditions causing increased catecholamine release have been established to be the main culprits. It therefore becomes very necessary for healthcare providers to be aware that massive GI bleed could be a potential precipitating factor. Thank you. Those are the references. Yeah. Yeah.
I'll ask a question. So what's the ejection fraction at 3-month follow-up?
So the ejection fraction, that's a good question. I've added that there. So it was clear that the ejection fraction improved, though it wasn't up to 50%, like what would have been expected, but it got up to like 45. So hoping that by the next follow-up visits, maybe in 6 months, we'll try to also assay what the EF will be at that time. Then I think I have a question for us here. My question is, what do we think was the pathophysiology behind the massive GI bleed causing the atypical Takotsubo in this patient? Based on the postulations regarding the pathophysiology of atypical Takotsubo, basically. That makes sense. And then something else about this patient, again, is that this lady was 73. She was also postmenopausal. So one could also say, could it be the fact that she's postmenopausal that may have made her more likely to come down with that? Because she's not just the only one that's had like a massive bleed. So why would she now have this with just... So maybe the postmenopausal syndrome made her more likely to have it than having this massive bleed, increased catecholamine surge, and then she was like tipped over. So that's it. Thank you very much.